Hi, welcome. Welcome to the Maryland Addiction Consultation Service webinar for today. My name is Sarah Merritt, and I'm a consultant with MAX, meaning that I'm one of the physicians who may be able to help answer your questions when you have a challenging case that you might like to discuss with another physician prescriber. And I'm going to present today on opioid prescribing in primary care, asking the question, where are we now? Again, this is me. I am board certified in anesthesiology, pain medicine, and recently in addiction medicine. So most of my practice, 80% is chronic pain management. I'm part of an interventional pain medicine practice, and we also have a portion, maybe 20% of our work that's geared toward addiction medicine, where we treat patients primarily with Suboxone on an outpatient basis, outpatient OBOT model. We have some patients that use Vivitrol alternatively for opioid use disorder and for alcohol use disorder as well. I wanted to say a few words about MAX as well to make sure that our audience knows the resources that we have that are available for you. MAX provides free services for consultation for clinical questions. Moreover, there are some education and training opportunities that you may, this being one of those education opportunities, training opportunities as well, including technical assistance as well to practices that are starting up or implementing new services. And then finally, there's an additional portion of the MAX portfolio where there are tele-echo clinics going on. There's one ongoing now, meeting monthly, I believe, doing some collaborative education. Presentations and case-based learning are part of this, and the echo concept, which you may have heard of, starting with some experts that are concentrated in one area, having them educate more experts and more experts so that we can help grow the knowledge and expertise that's in our community to better treat addiction, behavioral health disorders, and pain as well. Oh, and you know what? I didn't touch on bullet number 3 here. Actually, I should, because I've used that service myself. The MAX can also be used to help find resources for behavioral health. So for instance, if you were treating a patient who needed a referral for inpatient treatment, you wanted to find out where there might be inpatient beds available in your area, you can actually work through MAX to see if you can ask those questions with your patients, demographic information, such that they can, such that you can get their local best resources that are going to work with their insurance and have availability. So obviously that's a lot of pieces that have to come together to treat that patient who needs more intensive services sometimes, and MAX assists with that, which is such a need. All right, so I'm going to bring this up. My first slide is the elephant in the room. So this guy says, I'm right there in the room and no one even acknowledges me. So this always cracks me up because he's the elephant in the room. And to me, the elephant in the room that's worth bringing up here is that we're going to talk about opioids for chronic pain therapy, and that yes, you know, maybe they are appropriate, they can be appropriate in certain cases, but we need to talk about the elephant in the room, which is that they're not always, or not necessarily always, the best treatment for chronic pain, that they are one treatment, and that they may be the best treatment for an individual patient, but it kind of requires that individual patient having failed other treatments prior and having trials of course, non-opioid treatments, physical therapy, all these other things without appreciable improvement in function. So before we just dive in and talk about opioid prescribing in primary care and have a real discussion about where that is and the state of the field, I think it's worth mentioning that these are a reasonable treatment for chronic pain for some people. But let it be said also that, they're not always the best treatment, and the best treatment is really going to depend on that patient and what other modalities they've tried or had access to. So we'll briefly touch on the learning objectives for today. I want us to review the context and scope of the CDC guidelines for opioid prescribing. I feel like in 2020, if we're going to talk about opioid prescribing in primary care, you just can't neglect the CDC guidelines as being part of that discussion. And frankly, I'm not a primary care prescriber myself, but I think about and use and the CDC guidelines inform my practice because they've surveyed the data, and really those guidelines are based on the best available information. So while the CDC guidelines are really written with a focus for educating non-specialist prescribers, at the same time, they very much inform the practice that I have presently as well, in terms of the risks and the various considerations as we are prescribing and working with patients. The concepts are all there. I think we also need to review some of the strategies that may help primary care doctors or prescribers either feel more comfortable or positive about prescribing opioid medications in their practices, and kind of back to that elephant in the room. While on the one hand, I think there are prescribers who will, sort of hold their nose as they write a prescription. I think as you work on your own thinking around opioids, and if you really feel good about the prescriptions that you write, and this is the right prescription for this patient, that's the place that we all want to operate in, obviously. And if you're in a place where, the prescriptions you're writing don't jive with, your practice, or there are red flags, it's really a matter of just taking the right actions. So I think where there are corrections to be made, this is why we need, number one, that you know what to do if things aren't right. But then when, you have a patient who's taking a medication, responding to it, maybe we need to look at that and feel more comfortable, or feel like this might be a positive thing for this patient, all things considered. And finally, integrating all of this into your practice, of course, that you can actually use some of these best practice recommendations when you are doing your clinical decision making. So I just have a few figures and things to share with you here. That non-medical prescription opioid use is obviously a major public health issue in the United States. 2020 is the year of now coronavirus and uprisings, and we haven't talked as much about opioids this year, maybe outside of MACs and opioid prescribers. But the non-medical use of prescription opioids is still a huge thing that continues to happen, and may even be shown to be growing amidst the psychosocial stressors that so many Americans are experiencing. So there's a high number, at least 11% of Americans that experience daily or chronic pain, and it's there's some figures, there's higher numbers even than this, depending on the survey that you look up, who may experience daily or chronic pain that really isn't affecting the patient, but at least 11% are having the type of daily pain that's affecting their daily lives, affecting the activities they can do, affecting their ability to engage. So that's really a high number. We know really if you have that many Americans experiencing chronic or daily pain, those are 11% of Americans that might be, for whom a daily opioid might be a consideration. And at this point, opioids are still frequently prescribed for chronic pain in this country. Primary care providers commonly treat chronic non-cancer pain as part of their practice. I think appropriately so, for that patient who is doing okay on a stable dosage of medication, and the primary care doctor is not seeing problems or concerns. My position would be that that could be a very productive place to have the patient getting their prescription, because frankly, it'll keep them engaged with their care. As a specialist pain doctor, frankly, the risk is sometimes we'll have patients referred to us that we treat for medication management. And as I'm buffing up the chart, looking through things, and gee, who's your primary care doctor? And then they say, oh, I don't have one because I see you all the time. And that's really not a great answer, but that's the reality that we live in. And so if we can make sure that our primary care providers are comfortable enough with, they don't need to be comfortable with every opioid prescription, but to be comfortable with a certain range of opioid prescriptions, my position is that would be better for care of patients. And the concerns of those prescribers, of course, rightful concerns, I think, about possible risks of opioids, and then maybe insufficient training to feel comfortable providing those prescriptions. So I wanted to just share this, and we know that an underlying characteristic of the opioid epidemic has been an association between the increased rate of opioid prescribing and increased opioid-related morbidity and mortality. So we know that, and I have 1996 in my brain, and so you see this graph starts at 1999, excuse me, reflecting growth in opioid sales, growth in opioid-related deaths and treatments and admissions. This graph just ends at 2010. I don't think, well, I think opioid sales are down some. Our deaths and treatments admissions numbers are still very large, and clearly this is the part of time that has really led to some of the crisis level problems that we have now. So again, the year 1996, if we're thinking about these trends, was the year that OxyContin was branded and started to be marketed. So that's kind of the front end. The late 90s are sort of the front end of ramping up of opioid prescriptions in a bigger way across the U.S. So as a reaction to this, and I think some attempts to, as a reaction to this, there have been attempts to reduce inappropriate opioid prescribing, because presumably some of these prescriptions are appropriate at helping people, but some of these prescriptions are not. And how do we know which is which? And how do we help decrease the number of ones that are not beneficial or not well thought out or fraudulent in some way? How can we take steps to reduce inappropriate opioid prescribing? And so they're speaking with a group of primary care prescribers. I'm like preaching to the choir, because obviously all these things that we deal with on a daily basis, that are part of the regulatory environment where we attempt to take care of patients. So certainly many insurance companies have adopted policies to limit MMEs, or milligram morphine equivalents. A lot of that has been kind of a reaction or an attempt to apply the CDC guidelines to doctors, which is maybe a little, well, that's what's happening. I think there have been some concerns that that's maybe a little misguided. But we're seeing that, obviously, that certain insurance companies are trying to, I think, just raise the bar, make it a little more difficult to prescribe that high dose opioid prescription. And certainly, I think that is a measure that's within, to not make it impossible, but to really force folks to kind of think about those things, or think twice. Just have it be not the simplest thing to prescribe those higher dose medications. There are regulations by state medical boards. In Maryland, that's not been as prominent, but for instance, some states, Texas, maybe Tennessee, several states have required either specialists or primary care prescribers with a certain number of patients for whom they prescribe chronic opioids to register as a pain clinic, and they've required special registration, special fees, etc. That hasn't happened in Maryland, but that is something that's been done to try to reduce a potentially inappropriate opioid prescribing. There are requirements in some states to check the Prescription Drug Monitoring Program database, and in Maryland there is, as of July of 2018. Again, if you're writing an opioid or a benzodiazepine, you should be aware that there is a requirement that every 90 days, not every prescription, but every 90 days for a chronic prescription, that you're checking that prescription drug monitoring database. And again, there are limitations of days or of a prescription or a dosage. For instance, a reasonable limitation might be saying that you can't just prescribe someone of a 30 days of a QID medication if they are totally opioid naive, that might not be a first step, that shorter initial day supply of fewer than 7 days initially, and then further prescription may be approved. These have all been part of the steps to try to reduce endless, growing of number of prescriptions. And kind of to discuss separately, the attempt in 2016 to reduce inappropriate prescribing is really just introduction of the Centers for Disease Control prescribing opioids for chronic pain guidelines. There's lots to say about that, about those guidelines, and I think that we'll go through the bullet points of the take-home message. But I think overall, if you're going to prescribe opioids, it's important to basically understand them. You may look at the 12 bullet points and say, well, I do all that stuff already, and then that's great. Then you're good to go. But if any of it brings up things that maybe you're not already doing in your practice, it may help you pause and think about what you might want to incorporate. So the results of these attempts to reduce inappropriate prescribing have begun to occur. It's a process where at this point we are seeing a reducing number of opioid prescriptions in total in the US. And I think it may be worth mentioning now, if I don't think I mentioned that already. We talked about primary care prescribers probably provide about 50% of the opioid prescriptions currently in circulation. That includes acute and chronic pain. There's no differentiation from the hydrocodone prescription that a primary might prescribe for 3 to 5 days for an injury versus that chronic pain patient who is being treated for chronic pain by their primary care. Excuse me. So if we know already that a good number of prescriptions in the US do come from primary care, despite pain management doctors who prescribe higher total volumes over a month's time, despite surgeons who provide often many short-term prescriptions, there's still a very high number that come through primary care because of the volume of patients who need to see primary care. So the prescribing rate seems to be decreasing by around 5% from 2012 to 2016. And I would say it was 2010 that there was some data that came out from the Washington workers' compensation. Washington has a centralized workers' comp system that's different than Maryland's, and they have certain data that they're able to follow, and they were really able to show some increased risk of death in patients prescribed 200 milligram morphine equivalent. So this is patients prescribed opioids for chronic pain at a high dose, 200 MME or higher, that those patients had a substantially larger risk of death from all causes versus patients prescribed 50 to 100, 100 to 200, et cetera. There did appear to be a dose-response relationship. And then obviously at 200 and greater, the risk was significantly more. And so in my opinion, this, 2012, there was already some cooling probably of opioid prescribing, partly due to that awareness through 2016 when the CDC Opioid Guidelines came out. And again, we can see that high dosage opioids, this greater than 90 milligram morphine equivalents per day, the rates annually decreased almost 10% from 2009 to 2016. What this 90 milligram morphine equivalents, who says that's high dose, or where's the line for high dose, or is high dose greater than 200? Really, 90 MME is what is in the CDC guidelines. So I think that right now is the most common place to call high dosage, is anywhere above 90. So if you're not familiar with that number as sort of the trigger for thinking about high dosages, then now you're aware. If you don't know how to calculate an MME, there are many calculators online or that you could download on your phone, just to add that. Very, very briefly also, if the conversion for oxycodone to MMEs is just to multiply the number times 1.5. And so that, if you can do that, then you can do certain things in your head if that's a medication that you prescribe. If you're aware that maybe a patient who's taking oxycodone 10 milligram, how many MME or milligram morphine equivalents might that be? Multiply it by 1.5, so that's actually 15 MME. And I think this is where an awareness of those mathematical conversions can help prescribers know where do you lie in the bell curve of normal, where are you in relation to the normal or average prescription, high doses being greater than MME, 90 MME, excuse me, continuing to decrease, and I would say uncommon in the 200 and higher range, probably in primary care these days. I did want to show this slide just briefly. It's hard to find these two pieces of data on the same graph, and I sort of alluded to this maybe back here, that the things are changing a little bit, that we are still seeing the opioid prescribing rate still being high, way higher, right? Remember we talked about 99 or 96 maybe would be where opioid prescriptions really ramped up in the United States, and that these two things probably had a parallel increase. But maybe now that things have been decoupled in some ways, and not that it's not important to continue to monitor opioid prescriptions very closely, because it is, but we are finding in some places, and this is Ohio, not every state has this type of graph where the prescribing rate has fallen by this much, but there's really the curves, well, they were definitely associated here early on, they're sort of uncoupled at this point, where the growth in opioid deaths presently are not necessarily as clearly related to opioid prescriptions. I think let's talk briefly about the CDC guidelines then. So one of our learning objectives, just to make sure that you could, was to review the guidelines and make sure that we're able to apply them to practice. briefly, the purpose, use, and primary audience. They're intended for use by primary care providers, and it says that in the CDC opioid guidelines. Like I said, that said, do I think they apply to me? Yes, I think they do. But again, they are a guideline. And here's this slide. They're a guideline, and it's not an absolute, hey, you gotta always do what this says kind of thing. It's a recommendation. And it's intended to assist providers, intended to assist recipients of healthcare to make informed decisions. So ultimately, again, as a provider, prescriber, we're responsible for our own decisions, but the guidelines can help inform those decisions. And you, as the prescriber, you know your patient, you know what they've been through, they know, you know their history, and so it's important to let a guideline inform your work. But I don't think you need to feel hamstrung to do only what the guideline says in every single case. And I think that gets lost sometimes. There's room for the provider's judgment within reason, and that 80, 90, 95, 98% of the time, depending on your practice, you're going to do something in line with the guideline, but there needs to be that room that you could do otherwise, and not be wrong when that seems right for your patient. And that's ultimately what it's about, I think, is really doing the right thing for the patient. And so there's a lot of talk about what evidence-based medicine is. And if you read some of these insurance prior authorization requests and whatnot that you might get if you're an opioid prescriber, you might see something like, well, doctor, aren't you using evidence-based medicine? Aren't you going to abide by the CDC guidelines? And to that you would say, well, evidence-based medicine is, using the best medical evidence consciously with your judgment, that you're not to be blind to the situation, you're not to be blind to your patient's needs, but that you're to use evidence as best as you can to acquire, use the evidence as best as you can to apply it to that individual patient's situation. So I think this is like a pretty highly quoted little paragraph, and it helps me to kind of think about how we want to apply guidelines in our practice. I made this slide simply because otherwise the CDC guidelines, it gets very long because there's a lot in it. There's a lot to unpack, but I kind of like this one slide version because it really boils it all down. And this you can kind of digest to me because, like I said, you can kind of eyeball this and think about, what am I doing in my practice, and am I doing these things, and take note of what you might want to consider doing differently. So just to briefly, obviously you can read these. I'm going to bring them up again later, the slide, to show the different points. But the first few guidelines have to do with starting opioids, continuing opioids, and then, discontinuing or assessing risks and addressing any harms. So again, this is just like good medicine kind of stuff to know. Trialing those non-opioid treatments first, right? That's the elephant in the room, is that, hey, you got to start with this other stuff. Opioids might be a good treatment, but you don't start there. Goals and exit strategy. What's the purpose of this? Is this going to help get you out of bed? Is this going to help? I can go through my day on any given day and think about, what that person's goal is. For instance, I treated a patient this morning. We did a knee injection, but he also takes a low-dose opioid medication for pain, and it helps him continue to function and work full time despite some pretty significant physical limitations. And that medicine's serving a purpose for that patient. We can feel good that that's helping him. And as far as exit strategy, it set that expectation up front. Is this going to be a medication the patient may be on for a long time, and if not, okay, we're going to do this medication around your physical therapy for back pain, and really we're going to discontinue that afterward, or we're going to, give you some additional medication related to, increased activity due to whatever the reason is. Usually in my practice, it's therapy or rehab that patients are going through. Periodically reviewing the risk to benefit and the responsibilities of the patient. That again, it's the I think it's so important to keep that lens on of, this is for the patient's own good, and that if that patient is not, say for instance, I flushed my medication, or my medication got knocked off the nightstand and down the toilet. Okay, well then maybe that indicates that you're not storing the medication appropriately, and it's in your best interest that we only prescribe medications for patients who can care for their medicines appropriately. So I just want to share that because I think it's so important to frame those discussions in a way that's productive and shows the intention that you have as the prescriber, that, hey, we're doing this in your best interest, and being real about that the patient does have some responsibilities, and here's what they are. And if I'm prescribing you this medication, I might, expect you to engage in PT, or, whatever it is that are the goals or expectations on the part of the prescriber. Starting with immediate release preparations rather than long actings. Using the lowest effective dose and less than 90 milligram morphine equivalents are preferred. Different treatments for acute and chronic pain, just that truly for acute pain, consider not writing an opioid, first of all. Where does it say that? I guess that's number one. And then use the shortest duration, because as you probably know, as has been publicized recently, there are quite a number of studies that have come out showing, for instance, with postoperative prescriptions, patients given longer durations of prescriptions tend to stay on the medicine longer, sometimes even chronically. So using the shortest duration of treatment for acute pain is certainly indicated, and that for chronic pain, we're reassessing our plan within the first month. That we consider naloxone and other risk strategies, and I believe it's, there's a stronger statement than that from the state of Maryland for Medicaid patients, and for many of the insurance who do want you to require naloxone for your patients who might be taking a chronic opioid. Reviewing the PDMP, as we discussed, Maryland's going to want you to do that every 90 days. So you've already got that handled, that because you're following those rules. That you're going to perform the CDC guidelines, and maybe this is where it is sticky, that a guideline versus an absolute requirement. CDC guidelines suggest urine screening prior to initiation, and then at least annually. I know not all primary care prescribers may have that set up in their office. Avoid co-prescribing opioids and benzodiazepines together. That doesn't say never do it. That doesn't say no patient could benefit, but it says it should probably be avoided, which is probably true. And then to offer or arrange evidence-based treatment for opioid use disorder if the patient is diagnosed to have opioid use disorder. So arranging that follow-up. So I want to run through some case studies. I think I have 3 patients to share. And again, just to kind of refocus on primary care practice, I think that where are we in primary care right now? I want to share some of my experience as a pain specialist, and you can see a little of what I see, and that maybe some of these folks could be handled in primary care if they're if that's something that the primary doctor might feel so inclined to do. So Marianne saw me recently. She is a 65-year-old lady. She was referred by her neurologist, who was her second opinion neurologist, and she really had a story to tell. I've been to 7 doctors and I'm so irritated. She has daily headache, frontal, sometimes posterior type of distribution, diagnosed with chronic migraine. Says she's at the end of the road. She's tried many medications and interventions, non-opioid therapies, including Topamax, Neurontin, NSAIDs, triptans, physical therapies. Again, by the time she's seen 7 doctors before she's seen me, she's tried some reasonable stuff. And so then the plot thickens that she's actually already taking an opioid medication. So while we know that a lot of the neurology guidelines suggest that opioids maybe are not indicated for general management of headache, is it possible there are some patients that may benefit from an opioid prescription? Possibly. We have to take that on a case-by-case basis. This patient was taking tramadol twice a day with inadequate relief. And her neurologist wants to wean her because he's concerned that this 100 milligrams of tramadol is contrary to those guidelines. He doesn't want to prescribe the medication. Her urine screening is concordant, and prescription drug monitoring database is appropriate with no surprises. And so then we think about, what would you do? And so imagine maybe that this patient comes to you in a primary care clinic and that she is seeking new primary care, that she's not in the specialist clinic where I met her, but rather she's coming in looking for new primary care. What would you do? So let's pause a minute and talk about how likely primary care providers are to accept new patients taking prescription opioids for pain management. There's actually a little data on this now. First of all, it's pretty clear that a high number of primary care providers are going to be reluctant. Doesn't mean they won't, but reluctant, maybe a little hesitant. Maybe they just want more information to accept new patients that were currently prescribed an opioid. This was in a survey-based study by Dr. Gooden. And really, I think the likelihood of those primary care prescriber feelings are probably based on the desired result of reducing opioid prescribing from all these interventions I mentioned early on in the talk, that various regulations, guidelines, et cetera, have had this cooling effect. And so primary cares are just going to be less and less enthusiastic potentially to take on a new patient in particular who is being prescribed an opioid. And certainly I can share also, as a specialist, of course, I do see that there are a number of primary doctors, rheumatologists, folks who refer patients to me who say they have stopped or essentially stopped prescribing those patients, or at least that's what they tell the ones that they refer to me. And I think, interestingly, they may stop doing that even to those certain patients for whom it seems the benefits may outweigh the risks. So the University of Michigan has put out a study from some doctors in their kind of health disparities area, actually. And they did a secret shopper type of study. And they wanted to look at access to primary care clinics and patients with chronic pain receiving opioids. And so their result, in a nutshell here, was that they had these patients secret shop, ask for an appointment. They had a standardized plan, and they were able to show that 40% of these primary care clinics would not take on a patient on a chronic opioids. And so I would say that one of their conclusions, and I think this may be correct, that access to primary care is likely reduced for those patients taking prescriptions opioids, and it may lead to unintended consequences, such as even conversion to illicit substances possible or reduced management of their other medical conditions seems likely to me as a specialist who sees some of these folks who will then sometimes not see their primary care provider. So back to our friend Marianne. To Marianne with the headaches, I did agree to work with her with regard to the tramadol prescription. I agreed to take over this tramadol prescription for tramadol twice a day, and in fact, we discussed decreasing the tramadol and adding a tablet of Nucynta as an alternative. The jury's still out on how much this is helping, but I think we're going to at least give her this option, and if it isn't more beneficial, we'll return to her tramadol regimen. We've performed an occipital nerve block, which is a little different than the injection treatments that she's had. And right now we're still assessing her improvement. I think to a certain degree, she really just wants someone who will work with her a little and attempt to potentially continue the tramadol, which has been the most effective thing for her in managing the headache, and then B, also continue to look at some additional therapies as needed going forward. So let's talk about another case here. This is someone I saw just the other week, 70-year-old lady also. She came in using a walker. She had a prescription for 10 milligrams of oxycodone twice a day, but her current prescriber says that he can't give her any more than that. Well, she's really using this walker, and I think I should really describe her a little better to you. She's not just using a walker. She's really just hardly able to weight bear on this one leg. She has severe hip osteoarthritis on her x-ray. She complains of pain anteriorly over the left hip, consistent hip osteoarthritis, and she's already had an injection, minimal benefit. She's been advised to get a hip arthroplasty, but she doesn't have insurance currently. So what would you do? And I think there's no right answer here, but these are like the real world scenarios that people find themselves in. These are options that I would see as possible if this patient presented in primary care clinic. Would you refer her to the orthopedist to maybe prescribe until surgery? They could probably do that through someone on their team. She could be referred to the pain management, which is what happened in this case. Would you consider continuing her care in the primary care clinic? And in particular, I think partly because this 10 milligrams BID is ineffective, really what we ended up doing was increasing her to 10 milligrams TID and rechecking her. Because I've used cases that are very new, I can't tell you for sure regarding her result right now, but in my experience with a patient like this, that I feel she really just needs enough to keep her able to live independently until she can get that hip replacement. But to that point, again, like she might be better off in primary care because the primary care clinician is going to be more prepared to help manage maybe those home services, things like that, again, the primary care clinicians do so well. And if you think there's no clear answer to what to do for some of these patients, and if they were new patients to your primary care clinic, maybe it's because there is no clear answer and there's no one right way to do it. But again, I would encourage you to keep that lens on of what is the right thing for this patient and how can I use my knowledge, training, and experience to inform the care of this patient. I can share with you that there probably is not one right thing to do, but there are probably a number of right ways to handle challenging situations. And as long as you use that lens, you're going to be in a good place. I did want to share with you this large study from Virginia where they analyzed some electronic health care record for 84,000 patients. They interviewed 16 clinicians. And I have a couple of these quotes that I actually want to share with you maybe. So they analyzed EHR data for all these patients, interviewed clinicians, and looked at what are the challenges, or what is the state. Excuse me. The title of this paper is at the bottom: Chronic Opioid Prescribing and Primary Care Factors in Perspective. So it was like a survey, and then what was their summary? They summarized multiple difficulties in weaning patients from chronic opioids, including medical contraindications for non-opioid alternatives and difficulty justifying weaning. So this paper, this is like gold in here, where they have done these interviews with the prescribers, because it's so true. And so they have a table of quotes from these various clinicians in the practices. And so, for instance, a couple of themes of inheriting patients on chronic opioids. They asked clinicians about what their challenges were. They found clinicians feeling frustrated with inheriting patients on opioids. And these quotes are things like, "Her pain doctor got fired, loss of license. I'm not sure what happened exactly. The patient came to me very angry, but it was a difficult conversation because the patient wanted to just be on the same huge dose." So obviously that's going to be a challenging conversation for any prescriber, potentially, I think. On the other hand, there are other reasons that other reasons that prescribing for a certain patient or deprescribing might be challenging. For instance, complex medical comorbidities, or again, those contraindications to NSAIDs or other treatments for pain. So I'll wrap up with one more case, and then we can do a few questions maybe at the end. This is a patient who's been in my practice. 35-year-old male, prescribed oxycodone 30 milligrams 3 times a day. Started by, we'll imagine this was started by your predecessor in your office. He does not have a co-prescription for any sedative or stimulants, really just the oxycodone. And then imagine that maybe in the last year he's had one urine screen that was negative for oxycodone one time, and he said that was related to a travel where he ran out. But then your most recent urine screen that you're here to evaluate, it's actually positive for a non-prescribed fentanyl. And so what would you do? And I think you need to kind of know these answers in advance for your practice, what makes sense. For me, this patient was referred for other pain management. But in our practice, ultimately, we've ended up treating him for opioid use disorder. And I think that, you've kind of got those clues that this is a complicated case. I wanted to share a couple of pearls for dealing with those complicated cases. And again, I think it's good to keep, again, that lens on of it's really all about what's in the best interest of the patient. So if you have concerns for the PDMP, where you're seeing prescriptions from multiple sources, high doses or dangerous combinations, really discussing it with the patient and even maybe those other prescribers. If you feel like the patient's exhibiting criteria of opioid use disorder, it's really probably best to offer or arrange treatment of the opioid use disorder, rather than maybe the old answer, well, here's a 30-day taper of the medication, you just come off it and you're good. And that's really not the best option. If we know that the patient has an opioid use disorder, just weaning to nothing is probably not going to address or treat this problem if we're trying to keep our lens on of what's in the best interest of the patient. Again, and I would encourage you, even in whatever practice setting, consider trying not to dismiss them from your care. You can discontinue opioids without dismissing the patient from your care, because you can use this opportunity to provide potentially life-saving information and interventions. So the take-homes I think that I would offer you today, number one is absence of evidence is not evidence of absence. You may have heard this before, that there's an absence of evidence for long-term opioids treating pain effectively. But you've really got to look at that one case in front of you. There will never be long-term placebo-controlled trials of opioids versus placebo for pain management because there are serious ethical problems with doing that type of study. And so it won't ever be done. And so instead, you've really got N equals 1 of your one patient presenting in front of you, where you have to decide, what is in that patient's best interest. And I would encourage you to take the opportunity to say, I do that, and not, hey, let's send you somewhere else. But in those patients where you do see a role for opioid therapy, to consider treating the patient where you see a role, where you feel it's safe, and then refer for more specialized treatments when you feel like it's truly needed. All right. For questions, we can have you text them into the chat box, raise your hand, and we can address those. I'm going to come out of my full screen here.
I wasn't sure if someone was just trying to say something, or if that was background noise on your end. But so far we don't have any questions in the chat. I just want to remind folks to type your questions into the chat box and not into the Q&A. Also feel free to raise your hand or unmute yourself if you're able to. I guess while people are thinking of what they might ask, I did just want to remind everyone that you are eligible for CME and CEU credit for this webinar, as long as you complete the evaluation, which will come up at the end of this webinar. Once we exit out of the webinar, a screen will pop up on your home screen. Or if that doesn't work, we will also be sending an evaluation link through Qualtrics in the next couple of days. The recording to this webinar, as well as the slides, will be available on our website within a week, and we will also email those out.
Great. Well, I suppose that may just mean we don't have any questions.
Yeah, I don't see any questions or any hands raised. Looks like there might be one Q&A.
Okay.
Rhonda Johnson asked, she said, just a little bit hard to read, so bear with me because of the way it's set up. I was wondering if a person has challenges with opioids, why not educate them before? Sorry, it's really hard to see because I can only see one line at a time in here. Hold on, I can only see part of the question. Just a reminder for everyone to type any questions that they might have into the chat because it's a little bit hard to read the question and answers. Okay, so Rhonda said, I was wondering if a person has challenges with opioids, why not educate them before the medication is only short term?
Let me repeat that back to you, make sure I'm understanding the gist of the question. So the question is, if a person has challenges with opioids, why not educate them in advance that it's only short term? Is that correct?
I believe so. Rhonda, feel free to speak up if that is incorrect, or to confirm if it is.
Yeah, no, I think that's a very legitimate way to speak with a patient about an opioid prescription. And I think opioid prescribing in primary care consists of both acute prescriptions and chronic pain prescriptions. That's probably worth emphasizing is that for those acute pain prescriptions, and we kind of touched on that CDC slide, that 3 to 7 days is recommended for acute, and again, if you're that primary care provider who's, hey, I'm willing to write you a short-term prescription, but this is not for long-term, absolutely. And same in even in my clinic in a specialty setting where I may, be referred a patient, with the intention of, hey, we're going to maintain this prescription until you can get your surgery, for instance. There have been referrals like that we've had, where we're referred patients who might need a prescription temporarily until surgery, and that's the goal. We've really made that part of the dialogue and kind of part of the visit, to make sure that that's discussed, because certainly the longer that an opioid is taken, the higher risk there is for taking it long term. So I think, if you have concerns, to Rhonda's point, if you had concerns that a patient had problems with opioids, probably the best is just not to write that prescription. But if you need to, if it feels truly medically necessary, yeah, you should absolutely, why not just educate that person that it's a temporary measure? I think that's totally appropriate.
And then real quick, Naomi Abaga has a statement that she would like to share, where she says, I wonder if the Ohio study mentioned in the slide with data showing deaths trending in opposite directions, if many of those were possibly deaths from illicit drug abuse, for example, fentanyl obtained from the streets.
Yeah, I think that's exactly what it is. Absolutely. Correct that that there are new drivers of opioid deaths presently, and the big spikes, the higher death numbers, unfortunately, that we've seen in the last 2 or 3 years are absolutely related to those illicit synthetic opioids. And so I want to be cautious not to say like, oh, opioid prescribing in primary care doesn't drive that, because factually any prescription that gets into the wrong hands could be problematic, right? And so we all need to be good stewards of of our opioid prescribing, and prescribe when we think it's appropriate, to whom we think it's appropriate, and the amount that we think is appropriate. But right, I think unfortunately the continued upward trend is due to these other factors that have now kind of taken over, as drivers of those overdose events.
I don't see any more questions. I just wanted to put out one more reminder to feel free to send any questions that you might have after the webinar is over to max@som.umaryland.edu, which is on the slide. And also to sign up for Max, if you're a prescriber and you haven't signed up already, you can use the link that is in the slide, which we'll be sending out. The short link there, or you can visit our website, www.marylandmax.org. And also while you're there, feel free to sign up for our newsletter so you can get monthly updates for our events and any news in the world of addiction medicine.
Very good. Thank you so much, Anna.
All right, thank you so much.
All right. Thanks for joining us, everyone. Thank you.